Hey guys, we got some questions in our Facebook group, All on 4 Dental Implants discussion group that we've been trying to, help educate patients and answer a bunch of questions. I'm on there personally answering a bunch of questions on there. But about a month ago, we put on a little poll that said, hey, if you guys have some questions, we're gonna answer it for you. So here we are, and we're gonna give it a go at it. I'm Dr. Alistair Cree.
Dr. Spencer Russell.
So here we go. All right, first question. Who is a candidate for dental implants? Take it away.
Everybody. Dogs, cats, elephants, you, anybody. No, I mean, pretty much everybody we see, for the vast majority, are gonna be candidates for dental implants. There's only a handful of things that would preclude people from being a candidate. I think we've gone over that in a previous video.
The quick ones are radiation, very high diabetes, and some bone cancer medications.
And how often do we see that?
I would say 1 or 2 cases a year. And even then, there's been some times that there was a patient that had a lot of radiation, and we couldn't do what's called pterygoid implants in the very back because that's where the radiation was, but in the front, it was totally fine.
That's something we consulted with the oncologist with, or the radiation oncologist. They kind of tell us where is a good zone for the implants, where can't we go to do the radiation. So
there's certain ones at shielding. You can do certain things like hyperbaric chambers. Actually did a case of that quite a few years ago. It went perfectly, which just kind of drives a little bit of vascularity more in that bone that's been affected by the radiation. So there's things that you can do. So I would say 99.9% of people absolutely can. It is an extremely rare case that we can't do it.
Yeah, and we see people almost every single day that have been somewhere else. They were told they weren't a candidate for dental implants, they didn't have enough bone, or for whatever reason, they said they weren't a candidate. We see them and they absolutely are. So if you've been told previously that you're not a candidate, there's a good chance that you are, so come
and it's not just us. There's plenty of people across the nation that if you're used to handling some tougher cases, who can do it without even batting an eye, which kind of leads us into our next question.
Yeah. How do you decide between zygomatic, pterygoid, short implants, or grafting in severely atrophic cases?
That's kind of a loaded question. Again, we've had a couple videos on that as well, but so zygomatics, I'll go through what these implants are. Zygomatics are kind of your cheekbones. That's when like the bone in your dental alveolar bone, where your teeth are or where they used to be, is just not really existent anymore. It's kind of like a muscle. If you don't use it, you lose it in some scenarios. Pterygoids, I kind of mentioned that as well. It's the ones in the front here are normal implants, and the ones in the very back are called pterygoids. When I say that, they're basically the same implant, it's just, hey, they're in the back. So it sounds cool. Don't worry, it sounds like a nice little buzzword, and it sounds cool, and I sound like I really know what I'm doing. But it's just implants in the back. And all that is trying to get implants far enough back so you don't have any rocking motion, so you don't have a cantilever. Short implants, and it says, or grafting in severely atrophic cases. Short implants are more used for the mandible. The pterygoid and zygomas are more for the maxilla. Short ones specifically would be used more in the posterior mandible. So you have a nerve that comes on each side and comes out right around here. So sometimes the bone posterior to that is resorbed, severely atrophic. But if I still have enough height above that nerve, I can place what's called, basically it's an implant, it's just shorter, but it works very, very well in that situation. So obviously we don't want to hit the nerve. It's not so much a concern here in the front because there isn't a nerve here in the front to hit. It's more when you're trying to get that posterior implant in the back. So I guess going on to this specific question, so short implants are kind of different than zygomatics and pterygoids, but how do you decide between a zygomatic or pterygoid for the top?
So between those two, I would say the pterygoid is going to be a much more common option for a lot of people. So the pterygoid really comes into play when you're talking about a traditional all-on-4, which is what we do all day, every day. That's the most common way to replace an entire arch, is going to be those 4 implants. Now, in a lot of patients, though, your sinus is a little bit larger than normal, so it extends further forward.
When you say sinus, what is that?
So your maxillary sinuses are, if anybody's ever had a sinus infection, it's just this empty space inside your skull. And so there's no bone inside that area. So
would you say you have a larger sinus? You're a little more of an airhead?
Yep, I have giant sinus. I have a real light head that can just move around a lot. But no, I actually do have larger sinuses. Mine actually extend all the way up past my canines.
I do not have the issue. I have a lead head.
Yeah. I would not be the easiest case to do an all-on-4 on. But So a traditional all-on-4 in those scenarios when you have a larger sinus than normal would push that posterior implant further forward. And what this does then is if we didn't have this pterygoid implant, we have a lot of unsupported teeth. We would have 2 premolars potentially and a full molar that is unsupported in what we call a cantilever. And how I describe this to patients is, if you've ever had a table with a glass top on it, that you rarely have issues with that breaking. It's supported, you can push down on it, it's not gonna break. Now, if you were to slide that glass tabletop off the edge and you push on it, what's it gonna do? It's gonna snap off, it's gonna break off on the edge. And so you can kind of imagine that with a ceramic material. If you have this unsupported cantilever, it's gonna break. So what do we do in those cases where someone has a larger sinus that extends more anteriorly, or maybe they just don't have much bone back there for that reason? We'll add this pterygoid implant where you've got more bone behind your sinus, and that gives us an additional anchoring point, a support point, so now we don't have that cantilever. We're now supported on the back side, we're supported on the front side, and now we're gonna have that strength to reinforce this restoration.
And kind of expanding upon that, and you're saying, well, okay, what if I don't have good pterygoid or zygomatic bone? We really don't see that. So the bone where your teeth are does go away sometimes, and some people's it doesn't, but some people's it does over time when you're missing teeth. But the zygomatic bone and the pterygoid bone in the very back are just kind of like your arm bone. Like, it doesn't just go away. Like, your muscles might go away, but your bone will stay there. So it's very much the same thing. It's kind of more in tune with the body as not so much the oral cavity. So I really don't see anyone that doesn't have enough bone for that. And I do have one more thing about zygomatics. I see that actually in this group a lot. Tons of people are asking about zygomatics. I cannot stress enough that the vast majority of people do not need them. I do them, and I do them here with some regularity, but they are criminally overprescribed. And if you've been in this group, you've seen me say that so many times. And what do I mean by that? Is that people, and I know this sounds outrageous, but dentists think they look cool. And they do, don't get me wrong. But they're very advanced, and they just are not necessary in a large majority of cases. I mean, we do a vast amount of cases here, and I maybe do one of those a month, zygomatics. And I've seen people come in from they've been referred to me from different states, and they come here and I'm like, I don't have to use zygomatics for this. I'm not saying that you won't ever in your life, or that I won't do them. I certainly will, but it's more cost, it's a little more swelling. I'm not saying they don't work well, they certainly do, but why would you pay more and have more traumatic surgery for something that's not necessary?
And other potential complications that wouldn't arise, soft tissue issues and stuff like that.
Sinusitis. I mean, there's things that can happen with zygomatic implants. I mean, I'm not worried about anything catastrophic, right? You're not gonna hit any nerves really up here or anything, but it's just not necessary. And if you've been told to use zygomatics, I'm not saying that you don't. I'm just saying, check around. Like, it's usually, and so it's weird because I get both ways. I get some people saying, like, I was told I didn't have enough bone, and they're like, oh, you absolutely do. And then the other people saying, I have no bone, but I absolutely need zygomatics. I'm like, whoa, wait, you actually have. So I see both ways.
And our big philosophy, I think, is to always plan for that next step, right? Nothing in dentistry lasts forever. As much as we like it to, as much as we plan over engineer things, nothing lasts forever. And so I always want to have what is my next option if these implants, 20 years from now, have an issue or fail or something like that. And so if we can place traditional implants now, and then 20 years from now, then we need to go to a zygomatic implant. I've got that zygomatic implant in my back pocket. If we go to the zygos now, then what am I gonna do after that? And so that's where you wanna always plan for what is the next step? How can I take care of this case for a lifetime?
Well, I will say this. If you were gonna do a case on me, I wouldn't jump to zygomatics unless I absolutely had to. And if I had to, sure. Like, I mean, to do that or a denture, absolutely. I 100% would do it and wouldn't even hesitate. But if I don't have to, no, I'm not gonna do that. So enough about that subject. Next one, what are the customization options for dental implants? I'm gonna go ahead and assume they're meaning the teeth on this one. So I'll let you take it on that one.
Yeah, so if we're talking about what can we do on top of the implants themselves, we got tons of different options. We've done tooth tattoos. I think we did one, was it Bon Jovi? No, what was?
Ziggy Stardust, it was, What was that?
David
Yeah,
Bowie.
David Bowie.
We did David Bowie.
Thank you, cameraman.
Yes, we did a David Bowie lightning bolt. We've done Georgia, we've done Florida. You know, if you have your,
Done the U. The U's been out there.
The U was really nice, the Miami U.
I'm waiting on someone to put a Georgia G. If you're out there, go Dogs.
The Miami U colors popped really nice. I like that one. And then we've got diamonds. We actually just did one in the lab this past week where we did a gold front tooth on an all-on-4, zirconia everywhere else, but a gold on number 9, I believe. I mean, we've got titanium. I really want somebody to do the Jaws look where we've just got the full titanium metal mouth. No one's taken me up on it yet, but somebody out there wants it, so we can do it.
I mean, I tell people, I'm like, hey, whatever you want. I mean, there's no, and so he's going more like the wild options, but, and those are fun and crazy, and if you want it, come see us. But the small things that some people is like, you want sharper canines, we can do it. You want a little space in between your teeth, we can do it. You want it to be a rougher look, we can do it. You want it to look more natural, be more stained, we can do it. We actually have an arch. You want different gum colors, we can do it. We have an arch that we have, like, you know, for our consults to see, and we did all of these things on one arch. Just, no one would do that, right? But it's just showing like but if anything that you want, we can do. It doesn't matter, really, your wildest dreams, or even if it's just a little particular, if you want to copy a celebrity, there's nothing that we can't do because everything's done custom here as far as staining and glazing, and everything's also done custom as far as milling and designing.
Yeah, typically I tell people, you know, if you don't have anything you particularly want, we're gonna take 3D scans of your face, we're gonna take pictures, 3D scans of your teeth, I'm gonna get measurements, everything to design it to custom fit your face, the size of your face, the length of your face, everything like that. And then from there, if you have anything in particular you want, like you said, space in your front teeth, sharper canines, shorter laterals, any of those things, all of that goes into play when we do that design, so we can make it happen.
What is your most requested set of teeth? So actually, if you do want Dr. Russell's teeth, you can have them.
Yeah.
No, and we actually, well, and then we have another lady that we did, Denture Dame, perhaps seen online. We actually get a lot of people who requested her teeth. And actually, she made a reference to Blake Lively. So in essence, you are requesting Blake Lively's teeth. Not that we have an exact copy of hers, but we can obviously see the design of what her teeth are, and obviously they look great. But yeah, even if you want Dr. Russell's teeth, you can get them. Next question here.
All right, what are sedation options for the day of implant surgery? Are these procedures you do while awake, or is there an option for sedation for those with high anxiety?
So I would say our surgery is done 95% of the time with sedation. We do some singles and stuff that people are just like, look, it's not that big of a deal. And they're surprised how simple it is. But I would say it's very rare that we do, you know, a full mouth thing with no sedation. Every once in a while I get someone to request it. More power to you, it doesn't bother me. But most people are gonna want sedation. Different sedation options. Typically, I would say we do a lot of oral sedation here, which is Halcyon, which is a sedative drug that works very, very well. But stepping up from there, we also have a decent amount of people that request IV sedation. Our personal office, we bring in an anesthesiologist. So that's basically hospital level sedation. I mean, it's an anesthesiologist. It's not someone below. It's not an anesthesiologist assistant. It's not a CRNA. Not that they're not great at anesthesia. But if we're going to do it, we're going to do it right. It's going to be the safest thing imaginable. And so you will not remember that if you do have high anxiety. And I would say 99% of people have some anxiety. If you don't have any anxiety about having dental work done, probably it's a little bit rare. Hey, more power to you. But that's something we deal with every day. And there's other things that we do, like, you know, obviously a little more low key. Obviously we become familiar with each other. We turn the lights off, like we play with our music we want. Those are great things too. But yeah, sometimes anesthesia is just gonna be necessary, and that is absolutely okay. Does not affect the way the procedure comes out whatsoever.
Would you have sedation if you were having an all-on-4 done?
Yeah, I would have sedation. I mean, even though I don't mind it, like I'm not afraid of, you know, the needle, I'm not afraid of implants, I'm not, well, one, as I said earlier, I'm a lead head, so he's gonna struggle to get my teeth out, but, so I might be in there for a minute, but no, it would just, I mean, I've done it for my own parents too, like when I'm doing, you know, dental work on them, it's kind of like one of those things where like, why would you want to be around for it? Like, you know, like
if you were having any medical procedure done, you're gonna have sedation. It's the same thing here. The reason I asked that, I've seen this from dentists and other patients, and they're like, oh, they were gonna do an all-on-4, and they said I didn't need sedation. It's like, well, I mean, yeah, you don't need it, but it's gonna be more comfortable for you, so that's gonna be the best.
Well, I mean, we did this was 10 years ago now, we're getting a little older, but we did a course about wisdom teeth, and it was in the Dominican, and it was like an assembly line, and no one was using sedation, and so, because it wasn't available. And so, yeah, when the situation calls for it, and there isn't other options, or maybe it was 150 years ago, yeah, you didn't get sedation. You got a shot of whiskey and bite it on a bullet, but that's not necessary now. So if you have anxiety, that's okay, and we have plenty of things that can take care of it without fail. So, are implants better than dentures, and what are the differences?
Yes, full stop, end of discussion.
Yeah,
implants are better than dentures.
I mean, it's just, they're better in every single way. What are the differences? They look better, they feel better, they're smaller, they're stronger, you can eat whatever you want, less rubbing.
Don't come in and out. The only difference,
last longer.
Yeah, I mean, the only downside when you're comparing implants to dentures would be cost. Obviously, the dentures are gonna be a less expensive option for you, but in literally every other way, implants are going.
I mean, that's like asking, like, okay, well, is walking or car better than a bicycle, or a car better than walking? It's like, always yes. I mean, so it's really that far apart. And I know you're like, well, they're both teeth. No, I mean, they are, but they're not the same. It's like, all right, well, I could go 50 miles walking, or I could go 50 miles driving. It's like, oh, it's 50 miles either way. I'm like, yeah, see, but it's not the same, and that really is how far the gap is apart from having full implants to dentures as far as like your daily quality life.
Yeah.
All right, what is bone grafting for?
Yeah, so bone grafting is to either preserve the amount of bone you already have, or to rebuild bone that you've lost. So if you currently have a tooth in there, and maybe for whatever reason we need to take that tooth out and we can't put an implant back in at the same time. Most of the time, if we're taking a tooth out, we like to do an implant at the same time. But sometimes that root of the tooth takes up that whole area of bone, and there's just no additional bone for me to put the implant in. So we'll do a bone graft. So you already have this space, we take the tooth out, and now there's this empty space. If we don't put a bone graft in there, that bone is going to shrink. Now the studies show over that first year of healing, that could shrink as much as 70–80%. And in some people, it may not, it may only shrink 20%, but you're always gonna get some amount of shrinkage, and we don't know exactly how much that's gonna be because that varies person to person. So what can we do? We can fill that socket in where we took the tooth out, we fill it in with bone graft material, and now we're gonna minimize the shrinkage of that socket. We're gonna maintain that volume of bone you have, so that way when we come back when that's healed in 3 to 4 months, we can now put an implant in and not have any issues with it.
Also, just as a note, it's G-R-A-F-T, not graph with a PH like a chart. Just, I've seen that on there. Not that it matters, but just want to PSA.
Skin graft, bone graft, I mean, it's the same.
Graft. Yeah.
And so then another scenario, maybe you've had teeth taken out a long time ago, and your bone has, just like I said, it's shrunk. That bone, that alveolar bone, only exists to hold a tooth in place. If you've had that tooth taken out and it's been 8 or 10 years, that bone is almost certainly going to have shrunk down. And so it's going to shrink in there. I'm still gonna keep doing it, leave me alone. It's gonna shrink down, and then we're gonna put a bone graft in there, and we're gonna expand that back out. So if you had, say, 2 to 3 millimeters of bone left, we're gonna need more bone than that to put our implant in there. So we're gonna grow that from that 2 to 3 millimeters, and we're gonna make it 6, 7, 8 millimeters wide, so we have enough bone to then put that implant in place.
Think of it like this. At first, this is your bone now, and then that's what we're trying to make it is a lot larger. So that gives you a visual representation of what we're trying to do here.
A lot denser.
Yeah. And so some things, like I said, he was like, if it's filling up a hole basically where a tooth was, it's very simple. Some things are a little bit more involved. And we do all those complex ones when necessary. I wouldn't say it's very common, but we've done it quite a bit when necessary. Even on full arch cases at the same time, because I want this to last a long time, right? So I could do implants into a thin ridge and it'll work, right? But I've been doing this long enough to where I know what's gonna work long time, and long-term and not work long-term. So if I have to do something the day of to make this where I don't ever have to do this again, or at least the best attempt at never having to do this again, I'm gonna do it. I don't care, even if I got in there and it's not on the treatment plan. Can't tell you how many times we've both done that. We're like, whatever, just do the right thing, do it right, do it once and be done with it. And a lot of times that's involving some of that grafting.
Oh, and again, it's because we're planning for what is that next step. You know, if I leave this as it is, I put my implants in there, it'll be fine for right now. But if I don't graft that area where it's thin and this implant fails, then that patient comes back however far down the road, and now we don't have enough bone to put another implant into. So if we grow that now, we set ourselves up in the future to have a future site to put an implant in.
All right, well, yeah, so thank you guys for the questions. So we're very happy to be a part of this All-in-4 Dental Implants discussion group. These were fantastic questions, honestly. These were some of the ones that I see, talked about quite a bit, but it was nice to actually sit here and really discuss it, just between us. So I hope this helps somebody. And
yeah, Dr. Spencer Russell.
I'm Dr. Alex McCree. Thanks for watching.